We're here today and we're going to talk about a subject that we originally titled A Different Kind of Platform Switching to Preserve Bone and Soft Tissue. You know, when I looked at that title, it was a long time ago, and I started putting this presentation together. I go, what was I thinking? The platform switch concept, and especially when dealing with a subcrestal implant like ankylose, it's really not appropriate. But it was the title, so I said, okay, maybe just live with it. It's not a great title. Maybe it should have been, maybe it should have been an application of an implant system designed for subcrestal placement, optimizing implant aesthetics anteriorly. But it is what it is. Thank you for coming, and we'll do our best to kind of stay on subject today and utilize these principles. A little disclaimer disclosure from the beginning. I am involved in some research at the University of Florida that's sponsored by Dentsply Ankylose. However, I receive no compensation from Dentsply other than occasional and rare speaking engagement honorarium. I have no financial interest in the company, and nor do I serve as a consultant for Dentsply Ankylose at all. And also, as a disclaimer, I'm a private practice periodontist, and I use multiple implant systems in my practice, this being one of them. And I'm going to today share with you why I would use this in a particular situation. So, as we go on, I want to also give you some greetings from the University of Florida, our beautiful university in the northern part of the state. At one point, we used to have a reasonably good football team, those of you who follow that. We're part of a big health complex, part of the University of Florida. We're here in Miami, Gainesville, where the University of Florida is in the north. I live in Jacksonville, about 70 miles away. Those of you who don't know much about Florida, it used to be said that the northerners live in the south and the southerners live in the north. And if you don't know what that means, ask somebody. So, today, I want to, for a few minutes today, ask you all to open your minds, open your thoughts, and think a little differently about implant placement, particularly when aesthetics is involved. A little bit of all of you is going to be required to think outside the box, so to speak, and get the conventional thinking out. And we're going to talk about placing an implant, and I apologize, it looks like the projector is just not great. But you're not seeing this, but this implant is significantly subcrestally. And the conventional wisdom says you can't do that. You can't place an implant subcrestally and get away with it, for years and years and years. And I want to challenge you today to think that that's not true. And I do apologize. It's just not really great clear. But there's nothing we can do at this point. So now, as a periodontist, and all of us in the room, most of us in the room are periodontists, we're particularly anal. We strive and fight to create health around natural teeth. If we see this situation, and we do everything we can to, and you'll have to trust me that this is a reasonably healthy situation, around natural teeth, we're just very particular. We work our butts off with our patients to create gingival health, periodontal health, and it's a big part of all of our practices. Yet, and we do that with what I describe as histologic vision. We have histologic vision. We kind of look at gingiva, and in our minds, from our training, and that training is, all of you went through it, we have this mindset of what it should look like histologically in terms of what tissue looks like. Yet it's so ironic today when we think about implant dentistry, particularly some of the implants that we've done for years, that we accept a degree of inflammation. We accept a degree of bone loss, chronic issues relative to this. And in terms of these cases, we lose bone. Yet, when we look at these cases, they're particularly related to microgap issues, chronic inflammation. As a profession, we've sort of called these implants clinically acceptable. Clinically acceptable. And we have lots of them. In my practice, every day I see cases that I did, someone else did, chronically inflamed, exudate, patient's happy, doesn't know a thing that's going on, yet as a periodontist, particularly all of us that are excessive compulsive about controlling inflammation, we're limited, there's little we can do, and we accept some of these, and the profession itself has sort of given the stamp of approval that we have something that we describe as clinical success. But is it really? And if we didn't stamp these implants as clinically acceptable, we would all go crazy, because we would have zillions of failures in our practice. And it's a fine line between what we think is successful and what we think of failures. But I have 1 million of these in my practice, and I don't think there's a lot of difference between a chronic periodontal lesion and a chronic implant lesion, especially in regards to the fact that there's chronicity. But you know, the thing about a periodontal lesion, we typically can do something about it. But we have a very difficult time dealing with chronic lesions that are related to design. You know, the microgap. And the microgap being a leaking entity with chronic inflammation associated with it can be a long-term, decades-long problem. Yet, it still may result in an acceptable implant to the patient, an acceptable outcome to the patient, stability, and achieving its original goal of replacing a tooth. So, if you're like me, you've got a lot of these. And I have a lot of them in my practice. Some of them that I did years ago. You know, I look at these cases, I'm seeing 8mm pockets with exudate, bone loss, a couple of threads down, and I tell the patient, Mrs. Jones, you know, hey, I'm a little concerned here. And she goes, why? It's great. I love the implant. It's fantastic, you know. Well, is it really? And you know, we have issues relative to the microgap, and the literature is full of discussion about the potential for microgap being a considerable problem, particularly in regards to leakage, occlusal movement, fluid leaking in and out, bacterial invasion. It doesn't take a rocket scientist in periodontics today to know that we've got a plethora of articles that support that a microgap may be a chronic issue. So one of our discussions today is going to be talking about techniques to reduce the influence of the microgap. I mean, there are ways, and some of it has to do with improved technology, improved implant designs, and improved methodologies. You know, for one thing, the implant design itself has significantly improved. We've got some opportunities today to use implants that are better at preventing a problem with a microgap. And when we look at some of these, the first thing that we'll look at is the abutment connection, because the abutment connection may be the key things. And various implant companies have done things to improve this significantly. And part of it is the fact that, for instance, we have supracrestal designs, Straumann's type of tissue level design, which is a brilliant idea when you think about it. One interface, move the abutment implant connection, or in this case, the crown implant connection, supragingivally, or supracrustally, excuse me, and moving it away from the bone and putting it in a position where it's better adapted, and leakages associated with that have a minimal effect. We have designs like Astra design, excellent fit of an abutment to a implant, which are designed for crestal applications, and they work exceptionally well. And these implants, when placed properly in a proper position, quite well. A similar design is Straumann's bone level, placed at the crest of bone. Again, a design that does well when it's placed in a proper position. And then the one implant, the ankylose design, and again, I apologize for the crummy projector. The ankylose design, which is a subcrestal design, and truly a subcrestal design. Because as you'll see in this discussion, when you try to place some of the other designs in a subcrestal position, you're asking for trouble. But this implant itself is essentially a subcrestal implant, and specifically a subcrestal implant. So all of it has to do with the connections, where the connection is located, the type of connection, the quality of design, and how it's applied to a bone position. So abutment position, one of the ways to reduce the influence of the microgap is to consider two different ideas. One of them is the platform switching idea, which is sort of what the title of this thing was, because 3i introduced the idea that you would place an abutment that was narrower than the diameter of the implant. So essentially, you are medializing the abutment implant connection, and that's the platform switching idea, and then creating a distance. So you have essentially still an irritating microgap, but you're moving it further from bone. In a sense, it's a very clever idea. It was serendipitous, but it did occur, and they found that they had significant benefits when they moved it medially. And again, the Straumann design is not that far different when you think about it. Instead of moving it medially, you're moving it coronally. Either way, you're moving an irritating position, a microgap, and you're moving it away from the bone. And both methods seem to be effective. And we know the platform switching idea in the literature has gained a lot of support, and there's legitimacy to the fact that you can medialize the connection and end up with a significant improvement that way. These designs, and again, should be a better picture there, but these abutments move medially further from bone, result in less bone loss, and the literature certainly supports that. Now, the supracrestal design, or the Straumann design, is also very clever. And you can see kind of things every practice has their own little research going on, because you see things all the time. In this particular case, years and years ago, I put 2 Brannemark implants in. This is almost 20 years ago. In this case, where I put implant years ago for a 3-unit implant bridge. The patient loves it. I hate it, okay, because I look at it all the time. And I look at it and I see chronic inflammation. You have to trust me on this. The tissue is chronically inflamed, irritated, and the patient loves it. Then she ends up fracturing the central incisor opposite to that. And then this is about 9-10 years ago, I placed a tissue-level Straumann in that case. And when you look at that, here again, you see a tissue-level implant placed in a supracrestal position. And it doesn't take a rocket scientist to look at the comparison of tissue, and it's same with a periodontal probe, that you have a much healthier environment associated with this supracrestal design than these implants that were placed years ago. So you're looking at almost 20 years on these, almost 10 years on this one, and yet this makes me happier. Makes me happier. So here you're looking at a little test right in our hands of our own practice. So the abutment position could also be where you place. Even a good abutment implant connection, if placed in the wrong spot, could be a problem. So I inherited this patient over here, which had an Astra implant placed years ago, 7 years ago, and it was placed in a subcrestal position. Now, this is an excellent implant with an excellent abutment implant connection, but when it's placed significantly subcrestally, not by design, by its original design, you could end up with trouble. And here is a case where it was maybe placed a little close to the lateral, and yet, when you look at a 7-year radiograph, you see virtually no bone. As a matter of fact, you may even argue there's bone on the bevel. So this implant, in terms of its design feature, has lost virtually no bone. But the problem is that you look at this case, and you look at the results of this case, that this patient 7 years later, compared to, say, an implant placed at the crestal position, which this is the canine, and you could argue on this elderly lady, this is the healthiest thing in her whole mouth. But reality is, this is 7-8 millimeter pockets, significant exudate, significant issues relative to it, and occasionally an abscess. And that's when she comes in and she says, you know, this thing is swollen on me. But it really is not due to the design feature of the implant itself. It's more that's using an implant designed for a crestal application and placing it subcrestally. So let's focus in on this a second, because it's kind of interesting. Because it also has to do with something that we call implant geometry. And the geometry of an implant could be very important. Because if you compare, for instance, a ankylosed design placed subcrestally compared to this implant placed subcrestally, you're going to end up with a very different outcome, because the geometry, this very narrow neck, this physical space that allows essentially bone and soft tissue to occupy that space rather than titanium, seems to have a significant benefit. So if you could see this, and I don't even know if you can see it because of that projector, but I'm going to have to describe it to you. You're looking at bone on the platform, bone filling in this space, and the mere fact that this isn't occupied by titanium is a significant clinical benefit. So geometry of the abutment may be as important as anything else, because both of these implants have lost no bone. There is bone on that. That may be a better view of it right there, okay? And this is the same case at the 3-month point and the 5-year point. And the reality is, when placed properly in a subcrestal position, partly due to the geometry and space that the narrow abutment, the cone fit, allows, that we've been able to get exceptionally healthy tissue, exceptionally stable tissue, and bone that's on the platform, bone that virtually on the abutment itself. And actually, some of the literature relative to ankylose shows that there may ever even be bone to the abutment itself in Digiti's work. So, is this really platform switching at all? And I would contend probably not. Probably a completely different design. We're not switching anything. This is a cone fit where you have a very, very close fit in a cone socket relationship between an abutment and an implant with a narrow emergence with a exposed platform. And work done by Paul Weigel, photoelastic work, showed that there's virtually no opening of the microgap. So in his work, using this little video over here, when photoelastic work, he found no opening of the microgap at all. So in reality, this implant is acting like a one-piece implant. And one of my biases is, I love one-piece implants. If I could, in cases where I use Straumann, I'm losing a one-piece implant. I like it. But I also know that there's real limitations to that, and particularly in an anterior, high-end aesthetic situation, I'm not going to use that. I have to have something like that, and allows me a unique opportunity. So this connection seems to be very significant. So I would argue that it is not platform switching at all. It's a completely different design, a completely different fit, and a completely different outcome. Rather than medializing the effect, an irritating margin, I'm medializing a connection that has an encouraging margin with no micro leakage. And because there's no micro leakage, bone is actually on that platform. So essentially, if you did a cross-section of that and you looked at this connection, you can't even see it. When you do these EM stuff, look at these pictures, you can't even see where the abutment and the implant itself join. So it is essentially a one-piece implant. And no argument that the better the connection of the abutment to the implant, the more likelihood you're going to get bone on the platform. If it was a leaking margin, the bone would never form on the platform. So when you look at 3I's pictures and you look at these platform switch designs, I think it's quite different when you have a design that actually encourages bone to grow on the platform. So when you say that, you need to look a little at the history, because the history of this implant is quite interesting. It was developed by Degussa in Germany in the middle 80s. And the original design, up until even the turn of the century, was different. And it was actually thought of differently. It had a polished collar, a polished platform. It was positioned either at the crest or supracrestally. The interesting thing was that a lot of folks were placing these subcrestally, like any implant. We took every implant on the market and we placed them subcrestally for the purposes of getting emergence profile, aesthetic situation. We were in the trap with every implant that way. there are times you had to place it subcrustally. Well, when people started placing this subcrustally, they found that they had really good outcomes, even though it had a polished neck and a polished platform. So at the beginning of this century, the design changed to coating the surface all the way up, including the platform. And what you're looking at here is a design of 9, 10 years ago, and the notches you see are notches for the actual carrier of the implant. Well, that was eliminated a couple of years ago when the design went to a CX design, and the CX design has none of these notches, and although you can't see it, again, you'll have to take my word for it, there is indexing in this implant inside the implant. So the CX design has indexing. It has no notches on top, a very smooth surfaced platform that's coated. So my experience was years ago when it was a polished collar, you could place this implant supracrestally. You could place it equicrestally when it had a polished collar. But my experience now is this implant is strictly a subcrestal implant. And when placed at the crest or supracrestally, I think you're asking for trouble. In the old design, with its polished, I think that was okay. But in this design, you need to be subcrestal, and that's an important feature.